Good morning, everybody. It's a great privilege to introduce our virtual chief guest, well-known Chief Consultant Physician of National Institute of Infectious Diseases, Dr. Ananada Wijewickrama, the immediate past president of SriLanka College of Physicians. He is one of the most acknowledged academic in the country who has worked in the forefront of managing dengue and COVID. It is unfortunate not to have him with us today in person, but it is very fortunate to have him live amid his very busy schedule. So let's move on to his presentation. Over to you, Dr. Wijewickrama. Thank you very much.
Can I share my slides, please? You have to screen sharing. Good morning, and please give me a minute until I start sharing my slides. I can't share the slides. Good morning and Ayubowan. Thank you very much for your kind introduction. First, I would like to thank the organizers for inviting me to be the chief guest of this important event. In fact, when I accepted this invitation, I was planning to come to Badulla, and for two reasons. One reason was I was very happy to accept this invitation because after my foreign training after completing my foreign training as a consultant physician, the first station I served was Badulla. And then 18 years ago, yes, in 2002, I was the secretary of the Over Clinical Society. So because of these two things, I wanted to come to Badulla, but unfortunately, due to other unforeseen commitments, I had to join you virtually. Going with your theme, I thought of talking about facing, living, and working with COVID-19. The present situation as of midnight yesterday was this. The world has reported 96 million COVID cases. 24 million of those were from US and another 10 million was from India and so on. So each country, especially in the West and the Europe, we see a rise of COVID cases, including a rise of death. This is the new cases across the world and daily deaths across the world from the beginning of this outbreak. You can see how increasing both are, and as of just as of today, There are about 16,000 patients dying because of COVID. When you consider the mortality, initial estimated mortality was around 3 to 5% in China. However, death rate among patients admitted to hospital, the hospital fatality rate was around 15% in China. When you look at certain clinical trials, they also show a similarly high fatality rate. In the Solidarity trial, interim report showed a death rate of around 8 to 12%. And similar results, similar figures are shown in remdesivir trial, as well as actually the more higher rates are shown in the recovery trial, where even the dexamethasone group, which is supposed to have benefited from using dexamethasone, still has a mortality rate of 22.9%, which is a very high mortality rate for hospital admitted patients. The biggest challenge in this is the lack of treatment. Since the beginning of the epidemic, huge number of trials have been conducted and started. Just within 8 weeks of beginning of the epidemic, more than 300 clinical trials were started. And as of today, more than 4,000 clinical trials worldwide are being conducted on looking for a remedy for this disease. Most of these trials are from Europe, as you can see, and from North America. And surprisingly, the number of trials in Asia is not very high, in spite of we having various modes of treatment advocated and also thought of. Many pharmacological agents have been tested: antivirals, anti-malarials, antibiotics, monoclonal antibodies, and so on. However, as of today, no definite treatment have been found for this. The biggest complication we see in this is the pulmonary complication leading to hypoxia and respiratory failure. We look at a chest X-ray or CT scan of the chest in these patients, we would see multiple shadows for which the pathogenesis is not fully understood. This has resulted in various modes of ventilation, looking for more ICU beds and providing more ICU beds with ventilators, producing ICU ventilators, and so on. If you look at the UK figures, the usual ventilator production per week in the US was 700 in 2019. However, by end of April, this has increased by tenfold. It has become 7,000 ventilators produced per week in the US because of this pandemic. In spite of this, there had been excess deaths noted in the US, in other Western countries. And so thousands are getting infected, thousands are dying, and hospitals are overflowing. And in some places, the necessary protective equipments are running out of stock. The healthcare staff is getting infected. And because of all this, is the article from BBC. It says the threat of contagion can twist our psychological response to ordinary interactions, leading us to behave in unexpected ways. The article goes on to say, rarely the threat of disease occupies so much of our thinking. For weeks, almost every newspaper has stories about the coronavirus pandemic on its front page. Radio and TV programs have back-to-back coverage on the latest death tolls. We see in our TV and media as well today. And depending on who you follow, social media platforms are filled with frightening statistics, practical advices, and gallows of humor. The author continues to say, this constant bombardment can result in heightened anxiety with immediate effects on our mental health. But the constant feeling of threat may have other more insidious effects on our psychology. Due to some deeply evolved responses to disease, fears of contagion led us to become more conformist and tribalistic and less accepting of eccentricity. Our moral judgments became harsher and our social attitudes more conservative. And this has led to discrimination of patients by society, health facilities, criminalization of COVID-positive patients, closing down of factories, offices, etc., various restrictions, economic recession worldwide, and so on. When we look at the context of Sri Lanka, the first patient, as you know, was reported on 26th of January. That's a Chinese national. And the first local patient was reported on 10th of March. By early August, we had almost 3,000 cases with only 11 deaths. By that time, a lot of quarantine measures were adopted. Airport was shut down on 19th of March for passenger flights, and there was a travel ban, and there was mobility restriction across the country, and various financial and other allowances are given to selected populations, and only essential services and selected services were maintained. There was direct involvement from His Excellency the President and the top government people. There was task force headed by Director General of Health Services and Command of Army. And then there were many committees headed by key politicians, several committees in the Ministry of Health, and the quarantine facilities were handled by Army. As you know, there was a lockdown, close of airport, then gradual reopening. So we were doing pretty well. We can see there were small clusters, first from Navy garrison, and then from Kandakadu camp, and then this is from the repatriates coming from Middle East countries. However, in spite of these small outbreaks, they were well controlled and we were doing pretty well. And for 2 months, we didn't have cases from the community. And then we forgot we have to live with COVID. And we relaxed. Not only the general public, even the politicians, the political leaders, so-called, relaxed. You can see many were not wearing masks, and everybody who is wearing a mask is wearing it incorrectly. So that is the level of relaxation we went to. And that led to a beginning of another cluster coming from Minuwangoda. And this is the present situation, as you all know. And this indicates, and together with the world situation, that we will have to live with this COVID for a year or more at least. And this, across the world, has generated various scenarios or predictions. This is an article from the future, from the Nature, the pandemic's future. This is written by a researcher, and the researcher goes on to say a scenario in June 2021. The world has been in pandemic mode for a year and a half. The virus continues to spread at a slow burn. Intermittent lockdowns are the new normal. An approved vaccine offers 6 months of protection. This is a scenario, right? But international deal making has slowed its distribution. An estimated 250 million people have been infected worldwide, and 7.7 million are dead. So such scenarios have been thought of, and some of these could be true, at least to some extent. So what should we do? As doctors, I think our primary responsibility is towards the healthcare. So what we should do in hospitals? The priority number one is the safety of healthcare workers. In contrast to other situations where the priority in our work in hospital is the patients, in this instance, the priority of number one is the safety of healthcare workers. Because otherwise, the fear, if the healthcare workers are not protected, the fear itself will lead to refusal to see suspected patients, refusals to attend patients until a negative PCR is available, unnecessary use of personal protective equipment, employing measures to distance the patient from healthcare worker. We see some of these things are happening at present, partitioning wards, using robotic trolleys to distribute food, drug, etc., and then producing equipment for distant care. This is an article from Lancet. The topic is no patient safety without healthcare worker safety. So the primary aim is to protect the healthcare worker. And what are the measures? Most of these are simple measures: hand washing, practicing cough etiquette, avoiding unnecessary gatherings, maintain physical distancing, minimize touching surfaces unnecessarily, disinfecting surfaces, using face masks and wearing those properly, use of personal protective equipment appropriately and correctly. You can see most of these measures are simple when you look at them. However, practicing these things in our day-to-day life is not not that easy, and it doesn't happen regularly. He's one of our nurses who is prepared to go into the ward with COVID patients, and the right side shows a nurse is drawing blood from a patient. So with appropriate PPE, we attend to patients. Not only that, these are seen from our ICU. Wearing protective gears, we provide care, necessary care for these patients in spite of they being COVID positive. If you have the protection, then you can provide the care. So the second and third priorities should be the appropriate care and treatment for COVID negative patients as well as COVID positive patients. Now, this COVID positive patient in our ward, who was in our ward a couple of months ago, you can see I was doing a pleural, for you can't recognize me, doing a pleural aspiration, and you can see the pleural fluid is filling into the bottle of saline. So with all the necessary personal protective equipments, we do all necessary things for these patients, and that has to be the way. On the other hand, if you are not not doing procedures things so close to the patient, you don't need that much of protection. You can see a nurse is a COVID positive patient. A nurse is handing over a packet of rice to these patients. Both of them are wearing face masks and more than 1 meter apart, and that is enough. In these good ventilated wards with these half walls, we are keeping these patients in these wards, and you can see we are addressing some of these, giving instructions. So these patients, in fact, actually the patients organize a party for the nurses' day on that day. So we were having a chat with patients, and so when you take necessary precautions appropriately, you don't have to take unnecessary things. You can have these patients. Because you know the mode of infection. This girl's birthday, we made a little party, and nurse went in to the ward and arranged the party for them. And then at other times, the people who are well are allowed to come out of the wards and do some exercises, have some sunlight. It's not an issue. We don't have to keep them in an enclosed space. In fact, that can be bad. So once again, the key methods of prevention is what we have mentioned, and in addition, I would like to stress upon the fact of avoiding smoking in this. So we have to avoid things like this, and instead, I think we have to go back to our traditional methods, like saying this. Not only in our country, in countries like Thailand, India, we see these things. Then there are other issues in hospitals, preparing wards, improving facilities, changing habits and practices. And then, so as I said, we use open wards. We should not separate these wards and let them have proper ventilation. This is an article from a study in Japan which suggested there's 18.7-fold risk of higher transmission in indoors compared to outdoor environments, especially when combined with environmental factors such as poor ventilation and crowding in enclosed settings that will lead to further increase in attack rates. So that is why the good ventilation, less crowding, those are important. And this article further goes on to say, because overcrowded indoor spaces and gatherings likely will continue to be the driver of transmission, public health strategies will be needed to mitigate transmission of these settings. As part of the pandemic response, we may need to consider fundamentally redesigning these settings, including improved ventilation, just as improved sanitation was a response to cholera. So we have to think back, we have to get involved our architects, engineers, and have good ventilated places inside the hospital as well as other places. And then other problem is, one of the biggest problem is the changing habits. There are certain good habits and practices which you have to change. Our tradition is to join together to have meals, and such practices have to be avoided. And then we talk to people whenever we meet, those should be minimized. And then the tradition has become a tradition to have parties, gatherings, especially in things like weddings, funerals, and those should be avoided as much as possible. And then the biggest problem, another big problem we have is the exposure to a patient. And as I said earlier, the smoking plays a big role in this. These are some figures from a study from China. It says that when you take the total population of 1,085, 33% smokers in this population had severe or critical illness, in contrast to only 19% of non-smokers having critical and severe illness. So the smokers have a much greater risk of having the illness as well as dying from the disease. So once again, we have to stick to the key methods, and which has to be adhered to and advocated all the time. With this, and then it's a crisis. As Winston Churchill said, I believe we should not waste this crisis. It depends how you look at this crisis. You can look at this in a very negative point of way. On the other hand, you can see whether there could be, in spite of these negative things, there could be positive things as well. So what can we do as an institution, as a family or individual, and as doctors? As we, as in the hospital, work as a team, and these are the acknowledgements we got, and these are our team, part of our team. And in fact, we did not modify any of our wards. They are as they were. On the other hand, we got other facilities improved. This Air Force building isolation unit. You can see on the right hand lower corner the unit prepared, made. And then we got a CT scan and a radiology section donated by a group of engineers from Monato University. And then we got a molecular diagnostic laboratory. And then we got a new nursing quarters, even by the building was managed, or the process was managed by the Ports Authority chairman. So we got many things to the hospital. As an institution, I think we are doing well. As a family, what can we do? This, the professor of psychiatry and child and adolescent psychiatry says on this, the family resilience, the capacity for a family to weather and even thrive during adversity depends on a family's ability to balance stability and flexibility in changing circumstances. You know, our circumstances are changing pretty fast. This work in progress calls for an attitude of we are all in this together and let's do the best we can. I think that is what we should try to do. And there are many issues a family faces. Parenting relationship and having a constructive dialogue, because now the family is together most of the time with these restrictions, addressing the sibling issues and conflicts which are becoming more with this. And then on the other hand, you have to protect yourself and the persons you are careful. And caring for someone who is clinically extremely vulnerable, like your grandmother or grandfather, and then maintaining your own health while you are looking after others. These are some of the issues. Of course, there are many issues, but as a family, I think we have to look at that. Then on the other hand, there have been many inventions and innovations. These are few inventions from outside the Sri Lanka, and this delivery robot or transporting supplies in the UK. In Sri Lanka too, we have seen many inventions, and some of these are like this: the low-cost video laryngoscope made by a doctor, microorganism diverting and cleaning device, mechanical cardiopulmonary resuscitator, air seal intubation bag, foot-operated door handle, and so on. On the other hand, some of these inventions has, I wonder whether we have lost the human touch because of this. Some of these inventions, those are made in good faith, but probably not appropriate. I came across a nice article written by one Professor Ajit Alvis. He went in to say, inventions coming and going, when the dust settles, what may we have? So we have to look at this and think what we should have for the future and encourage such infections. And he ends his article saying, one big hope with the virus is that it would enable creating an ecosystem for the inventor and researcher to take the leadership for innovation. mantle of leadership for innovation. I think if that happens, I think as a country, we can prosper. On the other hand, the doctors have a big role in this. We have to advocate, and as an advocacy role, sometimes it is very difficult because we have to advocate to people, including politicians, which becomes very difficult. And then on the other hand, in organizing our setup, our hospital, the ward, the house, all that, I think we have a very big role as doctors in this setting. We have to take the leadership, especially in your hospital, in your units. You should take the leadership and get the team involved to face this crisis, because we will have to live with this crisis. And in addition, there's ample opportunity for other things like research and innovations, and we have to look positively and work for this, because we will have to live with this COVID at least for another year or two. Thank you.
Better patient care in the future. Now the floor is open for questions. Yeah.
Thank you very much for the kind presentation and also very informative one. And I am Dr. Nimal, a consultant community physician working in Nuvo province. So as for the participants, I would like to know the future trend of this outbreak in Sri Lanka, because the Ministry of Health is going to start the vaccination program in next couple of months. So what would be the situation of COVID-19 in coming months in Sri Lanka?
That will be a situation which is very difficult to predict. In fact, the Ministry of Health and the government of Sri Lanka is going to start the vaccination program not within months, hopefully within a couple of weeks. So the priority groups will be the frontline healthcare workers, and then the people above the age of 60, and also the people with selected comorbidities like CKD and diabetes. There are many issues with this. The vaccine has been several vaccines which are coming now, which are in the use, have shown an efficacy rate of more than 90%. However, nobody knows how long this protection lasts, because we had no time to see the follow-up. Generally, when a vaccine is produced or before coming to the market, it is followed up for at least 10 years. Due to the urgency of the situation, these vaccines had to be approved, and we hope that the protection will last for a long period. However, unfortunately, nobody can predict how long it will last. So it all depends on how the situation is. And then the other question is, like in the case of influenza, with the changing of with mutations of the virus, there may be viruses resistant to the vaccine is produced. So again, only the time will tell how resistant or how much that those resistant virus will prevail or spread. So all are in a very uncertain situation. So therefore, in spite of these possibilities of having vaccination and all those measures, I believe we have to take the necessary preventive measures to protect ourselves, our family members, and the community, because that is probably the only way of handling this or facing this crisis. And while doing that, I believe we have to continue with our work while taking necessary precautions. Otherwise, we can't just stop things, because this is not going to end soon.